Good morning. Welcome our RWJ site clerks, and today I want to welcome Dr. Gelfan's internship to our discussion on Seinfeld. The focus this morning will be on the episode The Blood. So any clerks have any observations on where they'd like to start this morning's discussion? Any particular scene, any particular character that caught your eye?
I think we could maybe start with Kramer.
What'd you see?
I think you can almost characterize his kind of infatuation with the blood as an obsession. He does seem to have intrusive, recurring thoughts about it. When the blood needs to be moved from one place to another, obviously causing him a lot of distress.
So when the blood is to be transferred, there's an observation in Kramer that there might be some impairment in functioning, perhaps interpersonal functioning, all caused by this maladaptive thought, this focus on the blood. We briefly reviewed this about a week or so ago. What we're talking about here are deficits in thought content. And for all intents and purposes in clinical medicine, an obsession, a rumination, and a preoccupation are examples and are, for the most part, interchangeable terms. There's a couple of commonalities here. Number one, as I stated, these three medical terms, again, rumination, preoccupation, obsession, are deficits in that area of mental status testing, specifically thought content. And they also share the quality that they are in the mild to moderate range. So they can certainly impair functioning. However, they really distinguish themselves as a group from yet another example of deficit called the delusion. The delusion separates itself from all the above by the fact that not only is it not reality-based, but it's also rigid, so that when the individual is provided information to the contrary, they remain fixed in their belief. Their thought content doesn't change. Is there any evidence that Kramer is delusional? And your answer, and again, your initial observation is just that, it's a provisional observation. So you're not going to rubber stamp this, you're not going to close the book on this. But the answer you give today, if today were the first time you were meeting your new patient named Kramer, has everything to do with whether or not we'll discuss conditions that are defined through obsessions, obsessive compulsive disorder, versus those that may be defined through delusions. Example, psychotic illnesses, including delusional disorder. Is there any scene in this episode, The Blood, that allows us to render an opinion that Kramer has actually provided some information that a reasonable person would accept and adapt their reasoning, but yet remains rigid? So I'm going to take the radio silence to say no, there's no obvious scene, which means then that this is likely an obsession, and obsessive compulsive disorder then would be in our differential diagnosis. Now, OCD would still be in our differential diagnosis, even if we arrived at this perhaps being a delusion, but it will be significantly lower. Where we are right now in trying to case formulate what's going on with Kramer, OCD is likely much higher in the differential diagnosis. OCD is a personality disorder that is categorized in a group called the cluster C. So the current nosology, the DSM, the current classification, allows for 3 groups or clusters because the different individual personality disorders do tend to share overlapping traits. Can anybody tell me the 2 other cluster C personality disorders that share common traits with obsessive compulsive disorder? Excuse me, obsessive compulsive. Now, I went off on a tangent. I'm talking about personality disorder. The two other cluster C personality disorders. Dependent personality disorder and avoidant personality disorder comprise cluster C along with obsessive compulsive personality. Now, to make this full circle, bring this back full circle, what is the difference between obsessive compulsive personality and OCD, that diagnosis that we currently are entertaining in Kramer in the episode The Blood?
OCPD is egosyntonic, meaning that they don't see their compulsions as intrusive in any way, whereas OCD is ego dystonic, meaning that the thoughts are pervasive and intrusive.
That is true, and that's what comes up commonly on shelf exams, I think, but in clinical practice, you can actually find rather easy examples to the contrary for both. That is, in OCPD, you can actually find evidence of it being ego dystonic, causing clinically significant distress or impairment. And the same can be said of OCD, where an individual has obsessions, but they don't rise to the level of being clinically significant. You wouldn't have the actual disorder defined then, perhaps just obsessive compulsive traits being identified. And I think an easy example of that are your mentors in medical school. Another difference between OCD, that condition that we're currently entertaining in Kramer, and obsessive compulsive personality, the personality disorder that is classified in cluster C of the DSM.
Is it like the level of impairment on the functioning of the person?
No, actually, both are very straightforward. To be called a disorder, you must demonstrate clinically significant distress or impairment. So whether it's OCPD or any personality disorder for that matter, versus obsessive compulsive disorder or any anxiety disorder for that matter, the level of impairment doesn't distinguish. Somebody described to me, and this is real easy question because the answer has already been provided. Think of Kramer. Somebody described to me a typical characteristic presentation of someone with obsessive compulsive disorder.
I mean, is it that somebody with OCD has like a very specific focus of the disorder? Like they have routines they might do, like washing their hands a lot. Like there's one thing or two things that they're very focused with, like in the episode, versus the personality disorder where it's can be like in all aspects of their life.
Kinda. Let's table the second part of that answer and focus, pardon the pun, on the obsessions. What you just provided is the answer. Obsessive compulsive disorder is defined through clinically significant obsessions and or compulsive behaviors. And it's very straightforward. And if you ever hesitate to try to recall the definition of obsessive compulsive disorder for your shelf exam, simply look at the diagnostic label. The DSM criteria are contained in the title. Obsessive compulsive disorder is a disorder defined through clinically significant obsessions and or compulsions. That's it. Let me reapply the same question now to obsessive compulsive personality. What's the characteristic presentation of someone with OCPD?
It can be like perfectionism overall.
Exactly it. It's exactly it. Perfectionism. um, order, control. It's your type A personality. Obsessive compulsive personality has nothing to do with obsessions. It has nothing to do with compulsions. Obsessions or compulsions are not found anywhere in the definition of OCPD, and that's the obvious difference. So the typical presentation to shift, and this may not necessarily be best manifest or demonstrated in the blood, happens to be Jerry Seinfeld, the character, someone who strives for perfectionism and order. And when not perfect, or when things are disordered or deemed out of his control, meets with clinically significant distress. That's OCPD. So it is true, shelf exam, artificial world, ego dystonic versus ego syntonic. However, in the real world, clinical practice, the two have really nothing to do with each other when it comes to presentation. One is an anxiety disorder with those manifestations of anxiety being obsessions and compulsions. That's OCD. And the other, the personality disorder, where the individual's personality traits are defined through perfectionism, order, and control. No obsessions or compulsions in the definition of obsessive compulsive personality. Right? That's the straightforward answer. Any other observations on Kramer? The only other thing I want to add, for those of you who might be true Seinfeld, the sitcom fans, is that if Kramer is being considered to demonstrate obsessive compulsive personality here, in the seasons previous to the blood, we would expect similar behavior. That is, any personality is stable over time. It's static, for better or for worse. So the fact that Kramer demonstrates clinically significant obsessions in the blood, if in every previous episode, in every prior season, there is no such behavior identified, this is very unlikely to be a manifestation of an underlying personality disorder, and therefore very unlikely to be secondary to OCPD. On the other hand, it will reinforce the idea of obsessive compulsive disorder, which makes a ton of sense here, right? What are the characters you want to discuss this morning?
I noticed with George, with his like food and combining food and pleasure situation, that he was like basically classically conditioning himself to equate food with pleasure.
Perfect. So you use a lot of big words there. All right. So name for me the other form of learning other than classical conditioning. Anyone?
Operant conditioning.
So let's start off with operant conditioning, because the blood is not about operant conditioning. So let's discuss that to get it out of the way. Somebody explain to me what operant conditioning is.
It's when you use either a reinforcement or a punishment to elicit a specific response. So you can either remove a stimulus or input a stimulus, either like a positive stimulus or a negative stimulus, to encourage or discourage specific behaviors in your recipient.
Perfect. Okay, so it's consequential learning. So I don't think this will come up in a shelf exam. Certainly for my undergraduates, this is more than fair game. Consequential learning attached to theorists like Skinner and Watson. A couple of take-home messages here for operant conditioning. Number one, any behavior that is rewarded or reinforced strengthens. So if you ever see a test question, and that includes a shelf question, and the answers are positive reinforcement, negative reinforcement, positive punishment, negative punishment, the very first thing I want you to think of is whether or not the behavior described in that clinical vignette strengthens or weakens. If you identify that the behavior strengthens, it must be a reinforcement paradigm, period. The second step is to ask yourself, was something added to the equation or subtracted? If something was added to the equation, the prefix positive will be used. If something was removed or subtracted, negative will be used. And if you just keep to those 2 points sequentially, you should never get a test question that focuses on operant conditioning wrong. So again, reinforcement strengthens behavior, and of course, punishment will abolish or weaken a behavior. And that must be the very first question you ask yourself, even if you read a clinical vignette and you think you automatically know the answer. Take the extra 10 seconds and go through those 2 steps to ensure you're going to get the test question correct. Right, so that's operant conditioning. Any questions about operant conditioning? Explain to me the basics of classical conditioning. That's a consensus answer. No, I'd rather not. Classical conditioning is learning by association. It's when an individual pairs a neutral stimulus, such as George's flushing, with I shouldn't say that. That's the response. I take that back. The neutral stimulus for George will be sex. The response would be the plethora or flushing. And then that's paired, in this case, with a deli sandwich, so that over the course of several pairings, George will elicit the same response, now called a conditioned response, to the pastrami sandwich, which will be labeled the conditioned stimulus. And that's exactly what happens in this episode. So this is a great episode to review learning theory and specifically Pavlovian or classical conditioning. Any questions about classical versus operant conditioning? Classical, learning by association, associative learning. Operant conditioning, learning by consequences, consequential learning. Pavlov versus Skinner. All right. Anything else strike your eye with George in this episode? Well, before we leave George, just a final thought on learning theory. A film, multiple films, but a particular film that demonstrates this, that really reinforced this, again, pardon the pun, is A Clockwork Orange. And in A Clockwork Orange, we see a couple of things that might come up in exams in the antagonist, Alex. Number one is that if paired over time with an inadvertent stimulus, the same learning can take place. So that, for instance, if we were to reapply this to Seinfeld's The Blood, over time, if George, while eating that deli sandwich in multiple pairings in bed, also was hearing a clock in the room, that inadvertent stimulus, the clock, may also over time elicit the same response. And we see this in A Clockwork Orange, something to look out for. And this is a variant of something called stimulus generalization. Right. Better example of stimulus generalization is that when George eats another type of hot dog, he actually has the plethora associated with it. And so stimulus generalization found on test as well. And if George were to stop this practice, similar to how Alex stops the pairings or in the Clockwork Orange, the government stops the pairings. Over time, that association will weaken. And there will be a day, and for George Costanza, folding this back and circling back to Seinfeld, perhaps in season 9, can have a deli sandwich and not have any response whatsoever. So if the pairings stop, then the conditioned response weakens over time. And that's called extinction. What are the characters? We're at 20 after the hour. We have about 5 minutes left. Any other characters you want to discuss from last night's Seinfeld episode, The Blood?
I found it interesting how Elaine was making herself like irresponsible to not take care of the child. That really called out to me because I guess she took on the responsibility she, I guess, deep down knew she couldn't take.
What do you think's behind that? How about starting with the observation that perhaps deep down there was apprehension and she was second thinking herself. Anything there? And the hint may be that if you've watched prior seasons, maybe the answer's hidden there. How much do you know about Elaine?
I've never watched it before. This is my first time, so I'm trying to like start watching.
Anyone?
It.
That's fair. What we know about Elaine is that she had a very difficult life as a child. She does make a comment in another episode that her father is struggling or perhaps even recovering from alcohol use disorder. I don't think her mother is ever mentioned in any of the 9 seasons. And only in one episode, she alludes to coming back, I think from St. Louis, seeing her sister. So we know very little about Elaine's family. And that's from a character that is a main character in what was a very popular sitcom. Know very little about her personally. We do know that, and the little that we do know, she had a run with her father. And the 3 or so episodes that her father is in, he portrays a very cold and emotionally distant parent. So what Elaine feels regarding her own self-efficacy is challenged. And that would include any kind of quote unquote maternal-like instincts. And that might be linked to early childhood experiences and more specifically that family dynamic. And when she makes a commitment like this, especially when the focus is going to be a child, there's probably some level of transference here where she's about to take care of a child and she perhaps even subconsciously recalls having been taken care of as a child. And there's probably conflict there. So it's probably better for her to sabotage it than to follow through with this level of apprehension she has. I alluded to a condition, alcohol use disorder. We no longer, that is psychiatry, the American Psychiatric Association no longer uses the phraseology, the nosology of alcohol dependence versus alcohol abuse. Those terms have been done away with in terms of diagnoses in 2013 with the addition of the DSM-5. What basically happened is that the APA took those related terms, dependence and abuse, and they apply to every substance, alcohol being the example here in the blood, and they combined the two. So previously, DSM-4, an individual only needed to have a single criterion to rule in for substance abuse and 3 for substance dependence. Combine those criteria for the most part and take the average. You need 2 or more and you rule in for substance use disorder, in this case, alcohol use disorder. I think the major change in the criteria, other than combining them, is that the APA introduced craving as a new criteria that did not exist in previous editions of the DSM. They removed legal infractions as a criteria, so they exchanged one for the other. But otherwise, really, it is the same criteria from those two separate sets of use and dependence combined, and now you need a total of two. And I think if we, and I don't know it might be the jacket now that I think of it. In the jacket episode, when we do actually have Elaine's father playing a rather prominent role, we could look to see if he has two or more criteria. But unfortunately, a lot of the dialogue in that particular episode is his history being discussed outside of his use of alcohol. It's only a comment that Elaine makes that he's an alcoholic, AKA substance or alcohol use disorder. Final questions, observations, thoughts? Quickly, we have 4 minutes left to the bottom of the hour. You treat someone in the hospital, perhaps it's Elaine's dad, with alcohol use disorder. He, let's say, goes through a withdrawal phase. He is through his withdrawal phase, and you see him on his final day of hospitalization. You want to transfer him to outpatient care. He's acceptable. He's at the action stage of change. He meets with a social worker, case management, and is set up for an outpatient appointment. In a week or two, he follows up with his outpatient psychiatrist, and that is you. You are now putting together a biopsychosocial treatment plan. There is no co-occurring mental disorder. Single diagnosis, alcohol use disorder, in early remission. And you want to discuss with him biological or somatic treatments for his condition. What are the 3 medications FDA approved in this context?
Naltrexone, acamprosate, and disulfiram.
Perfect. So naltrexone, how does it work? What's its mechanism of action? Anyone? It is a mu opioid antagonist. And as a mu antagonist, it will reduce the craving of opioids. That's pretty straightforward and is FDA approved in the maintenance management of an opioid addict, somebody with opioid use disorder. Because of the cross-receptor sensitivity, it was observed that individuals taking naltrexone also had reduced cravings for alcohol. And because of that, this medication gained FDA approval for alcohol use disorder as well. So mu opioid antagonist. Acamprosate's mechanism is somewhat more poorly understood. It looks to be chemically similar to GABA. So people believe that there's a fairly significant GABAergic mechanism that reduces cravings as well. So you have both of these medications reducing craving. One through its block of the opioid receptor, specifically the mu opioid receptor, and the other through less understood mechanism. How does disulfiram work? And I'll give you a hint. It's not by reducing craving.
It
It creates like really unwanted side effects by blocking acetaldehyde dehydrogenase. So it lets like the like toxin build up and create just it's a very uncomfortable feeling. So like it works with patients who are more like motivated, I guess, or like more adherent to like quitting. So they're not regularly drinking.
And we could say that for all 3 medications, right? Definitely better outcomes for more motivated patients that are at the action stage of change. So yes, by blocking acetaldehyde dehydrogenase, the rate limiting step, the enzyme that catalyzes the rate limiting step of the breakdown of alcohol, by inhibiting that reaction, the individual has a buildup of aldehyde, and that's toxic. So if they drink while taking the medication, They could feel nauseous. They can become flush, faint, diaphoretic. And the next time they think of picking up beer or alcohol, they'll think twice. What form of learning is that? Be careful. Don't jump at an answer. There are 2 steps here. Who wants to take those 2 steps?
I can try.
So
It's hard. Oh, go.
What's the first step?
Well, I was going to say you're adding in something, so it's positive, and then you're doing it to take away a behavior, so punishment.
Positive punishment is correct. Okay. I can't tell you how many people will quickly blurt out negative reinforcement. Right? It's positive punishment, right? Stick to those 2 steps. You will never get the question wrong. Right? And we'll end it there on that high note. Right? So I will see the red team in about 40 minutes or so. We'll begin rounds. For our interns, we will have table rounds over Zoom. I'll see everybody back then. Thank you.